Now I'll open the floor for the question and answer session, and then we'll be heading towards a group photo. Yes, Dr. Arzu. There's a mic over there. Anybody who has a question, they can please come in towards the mic.
Head of Nuclear Medicine and PET-CT Division at Inmol Cancer Hospital. I would like to thank all the 4 speakers for very informative talks. But my question is pertaining to the talk that was delivered by Dr. Hussain Jadwar. It was an amazing 20 minutes or so because, in that talk, he covered almost all the challenges that a treating physician can face while using radioligand therapy. So I have 2 questions because earlier today, I also delivered a 40-minute talk in one of the workshops pertaining to lutetium-based radioligand therapy in treatment of prostate cancer. So there are 2 challenges that I'm particularly interested in. Patients who present with diffuse bone marrow involvement, should we not consider actinium in these patients upfront instead of first subjecting them to lutetium therapy? And number 2 is that in case of non-responders to lutetium, because like you mentioned, we should at least give them a chance with 2 cycles. But if after 2 cycles we are responding, should we at that time consider going towards actinium therapy? And do you have any personal experience of using actinium? And what about the challenges involved in logistics and the side effects pertaining to the salivary glands and to the kidneys, that is the nephrotoxicity? Thank you.
Well, thank you for the question. First of all, I personally do not have experience with actinium. Actinium agents are not FDA approved. They are not available in the US, and also it is being essentially used either in clinical trials or for compassionate care in some other countries. So it is not mainstream. But to answer your questions, yes, if you have a disease, it because of the short range and very high LET, usually that seems to work better, although to make a final decision, you really need to trial and see what the efficiency and effectiveness is, and also what kind of toxicities will develop. With regard to xerostomia, it is a major problem with actinium or other alpha treatments, as you know. There have been several approaches to address this issue. None of them have really been the best at this point. The one that has been Mark Satheki from South Africa, who has, I would say, one of the people who have most experience with actinium, although there are also others in Germany like Clemens Kratochvil and others. They suggest that you should really use the higher dose at the beginning, like the first dose, and then you can kind of taper it down. So you kind of hit the cancer with the best shot you have, and then you try to bring the dose down in a de-escalation, in essentially a schedule, to, and it seems that that way you really can in some sense protect the salivary glands as opposed to give a regular scheduled same dose. Again, but these are all kind of anecdotal evidence in few patients. And we need clinical trials to really see, if we want to use actinium type of treatments up, and if we are doing that, what kind of a schedule is the best?
Thank you, Dr. Jadwar.